Ventricular septal defect. No visible pulsation. Apex beat left fifth intercostal space just lateral to mid-clavicular line. Forceful but ill-sustained. Systolic thrill over left lower parasternal area. No left parasternal hip, palpable P2 or epigastric pulsation. First and second heart sound normal. A harsh pansystolic murmur heard all over the precordium but best at left parasternal area, grade 4 by 6 in intensity with no respiratory variation. Lung vases are clear. So, what is your diagnosis? It is ventricular septal defect. What are the differentials? Mitral regurgitation, tricuspid regurgitation. Tell me some differentials for left parasternal systolic murmur. VSD, mitral regurgitation, TR, ASD, pulmonary stenosis, aortic stenosis, hypertrophic obstructive cardiomyopathy. Don't forget about primary pulmonary hypertension in young female. Why MR is your differential? Pansystolic murmur. When MR is due to PML prolapse, it may radiate towards base of the heart. Why this is not a case of MR? In MR, first heart sound will be soft. Pansystolic murmur, best heart at apical area will be increased in breath hold after expiration. Why not TR? In TR, maximum grade will be 3 by 6 will be increased in breath hold after inspiration. I will also get evidence of pulmonary hypertension. What are the types of VSD? Membranous, muscular, inlet, outlet, and doubly committed. Which one most common? Membranous, 80%. What do you think? Is this small or large VSD? Sir, intensity of murmur is inversely proportional to VSD. In my patient, murmur intensity is high and patient has no evidence of pulmonary hypertension. So this may be a small and restrictive VSD. But apex beat is shifted. What does it signify? It signifies that although small, but VSD is hemodynamically significant. What is restrictive VSD? QPQS ratio is more than 2.2 is non-restrictive. If it is less than 1.5, then it is severely restrictive. If it is between 1.5 to 2.2, it is moderately restrictive. What do you mean by small, moderate, or large VSD? Less than one third of aortic annulus is small. Less than half, it is moderate. Equal to is large. How will you investigate? ECG, chest X-ray, PA view, transthoracic echo with all modalities. What is the expected ECG findings? Evidence of LV enlargement, LA enlargement, pulmonary hypertension. It is case specific. Expected X-ray findings: cardiomegaly with LB type apex, LA enlargement, plethoric lung fields, evidence of pulmonary artery enlargement, evidence of pulmonary hypertension. What you want to see during echocardiography: confirmation of VSD, location and size of VSD, detect and quantify the severity of pulmonary hypertension, evidence of LV enlargement and LV function, associated lesions like ASD, AR, MR, TR, PS, PDA, decision making for treatment modalities. Which view is best for detecting which type of VSD? Left parasternal short axis view, left parasternal long axis view for perimembranous and muscular VSD, left parasternal short axis view at grade vessels level for perimembranous and outlet VSD, left parasternal short axis view mitral valve level and apical 4-chamber view for inlet and muscular VSD, Apical 5-chamber view for outlet, perimembranous and muscular VSD. Which type of VSD may not be detected by transthoracic echo, muscular VSD? If there are any confusion regarding decision making, what next investigation you want to do? Cardiac catheterization. Which heart catheterization? Both right and left heart catheterization. What do you want to see? Catheter trajectory, step up of oxygen saturation from RA to RV, evidence of high RV pressure in pressure tracing, pulmonary vascular resistance, reversibility test in borderline cases to detect the treatment modalities, RB graphy to see associated pulmonary stenosis, LB graphy, aortography to see associated coarctation of aorta and PDA. What do you mean by step up of oxygen? 5% increase of saturation from RA to RV. Can you tell me the other causes of step up of oxygen from RA to RV? Yes, sir. PDA with pulmonary regurgitation. Rupture sinus of valsalva in RV. Will catheter trajectory help in a small muscular VSD? No, sir. But step up of oxygen and pressure tracing will help. In case of borderline cases for Eisenmenger physiology, if reversibility test also borderline, what will be your decision? Closer or not closer? I will rather allow Eisenmenger physiology. What are the modalities of management? Medical management, closer either by device or surgical. Don't forget to mention about infective endocarditis prophylaxis. What is the name of device? Amplurge septal occluder for muscular and membranous VSD. Rushkind double umbrella not used now. Clamshell device not used now. Is spontaneous closure possible? Yes, sir. In muscular VSD, spontaneous closure occur in 80% cases. In perimembranous VSD, spontaneous closure may occur in 30% cases, but this is unlikely if closure does not occur within 10 years of age. How membranous VSD closes? Growth of surrounding muscular septum and aneurysm of septal leaflet of tricuspid valve. If left untreated, which may be the possible complications? Pulmonary hypertension and Eisenmenger syndrome, CCF, infective endocarditis, paradoxical emboli, arrhythmia. Infective endocarditis more common in ASD or VSD. Why? Greater turbulence of flow and more endocardial injury. What is the commonest site of involvement? Septal leaflet of tricuspid valve. Pulmonary hypertension more common in ASD or VSD? More common in VSD. Why? Due to proximity of pulmonary artery and more shunting of blood from left to right. What are the contraindications of VSD closure? Severe pulmonary hypertension, high pulmonary vascular resistance when it is more than 5 Wood unit. What is the contraindication of device closure? Close proximity to any of the heart valves less than 4 mm. Also mention the severe pulmonary hypertension. What is Melody de Roser VSD? Small VSD in membranous septum with thrill and tearing pensystolic murmur. What is its significance? No need to surgery, but infective endocarditis prophylaxis is mandatory. Thank you.